Hello everyone, let's look at this topic of clinical series which is related to wound healing. So the first question is what is the spot diagnosis? So you can see here this is something like an abnormal wound healing where the hypertrophic tissue or whatever the abnormal deposition of collagen has crossed the normal border. So this is nothing but your keloid. Whereas this picture will show you that hypertrophied or whatever excess collagen that is deposited, it is confined to the suture site. So this is nothing but your hypertrophic scar. Okay, so they are mainly asking about this one. So the spot diagnosis is your colloid. Sorry, so the spot diagnosis is keloid. Okay, right. Next, what is the other abnormal wound healing? Just now we have seen the other abnormal wound healing will be hypertrophic scar. So what are the characteristics of keloid and hypertrophic scar? Please understand both are abnormal wound healings. More frequently we encounter clinically is your hypertrophic scar, whereas keloid is little bit rare, and usually both will happen at the site of previous suture site or where the scar is there. Then regarding the keloid, there is an important point called keloid triangle. So what is keloid triangle? Let's say for example, if this is the upper trunk and we have the junction of this both shoulders as well as this Ziphisternum. This area, whatever the, so this is your Ziphisternum. The area present between these 3 points is called your keloid triangle, where the chance of keloid is very high. Okay, right. So as you can see, the familial inheritance will be something in autosomal dominant pattern in case of keloid, and there is no such genetic pattern in case of hypertrophic scar. Usually, this is something hypertrophic scar occurs after 4 to 6 weeks approximately, whereas keloid is one area where we see clinically somewhere after years or something like a months. Okay, right. Next. So as you can see here, mainly it will be pruritus and pain in case of keloid, whereas it is something like a, again pruritus is present here in hypertrophic scar as well, but it will respect the wound. So it is confined to the scar site, that is hypertrophic scar. Next, so usually there may be a chance of a frequent spontaneous regression in case of hypertrophic scar, whereas there is no such scenario in case of keloid, and there will be frequent contracture that will be seen in hypertrophic scar, but it is rare in case of keloid. Please understand the orientation of collagen fibers is something like a very parallel in case of hypertrophic scar, whereas if you take keloid, this is something like a wavy pattern. This will be irregular and a haphazardous pattern, and random orientation will be there in keloid. Okay, right. Next, what are the important factors which will cause the delayed wound healing? Please understand these factors can be divided into local and systemic. Local and systemic. When it comes to local factors, we can see here one is skin tension. Whenever there is a localized infection at the site of wound, any foreign body, vascular insufficiency, and inadequate rest, then hypoxia, lymphedema, and radiotherapy. So you can remember something like a neurovascular bundle. So N is something like more related to diabetic neuropathy. So vascular, again, this vascular can be divided into arteries and lymphatics. So again, in arteries, it is arterial insufficiency, and in case of lymph, it is lymphedema. Okay, so any localized infection will hamper the wound healing. So we need to be very careful about the localized treatment. So the local treatment of that particular wound. Now, coming to systemic factors which will delay or affect the wound healing, we can understand or remember them with the help of the headings of the case sheet. So we will see what are all the important systemic factors. First one is age. So you know that elderly age group is immunocompromised state. So you can have delayed wound healing in elderly age. Next is gender. There is no such correlation here. But when it comes to, let's say for example, past history. So after patient details, chief complaints, then history of present illness, and next is your past history. So in past history, any history of comorbidities, something like diabetes mellitus or TB, then CKD, which are all immunocompromised states again. Then when it comes to personalized history or personal history, in personal history, any history of either smoking or alcohol consumption will delay the wound healing. So again, these are the important factors. And when it comes to family history, any history of collagen disorders like any syndromic associations, etc. So any syndromes like syndromes of collagen abnormality. Then after past history, family history, personal history, then is your treatment history. So in treatment history, any medications like any steroids or it can be chemotherapy drugs, again, which will suppress the immunity or immune system, which will delay the wound healing. Then, after treatment history, general examination. When it comes to general examination, one important thing we see is pallor, pallor erythrocyanosis clubbing generalized lymphadenopathy. So, pallor, which will indicate anemia. In anemia, there will be decreased hemoglobin or decreased oxygen carrying capacity, again, which will delay the wound healing. And another one is malnutrition. This malnutrition can be undernutrition or overnutrition. So malnutrition is another important factor which will affect the wound healing. So this is how we can remember the systemic factors related to the which will delay the wound healing. So if you remember the case sheet headings, we can easily remember the systemic factors. Right. Next step. What are the important phases of wound healing? So again, please understand the whenever we have any wound in the acute phase, there will be something called. So the overall phases can be remembered with the help of mnemonic HIPAR. So H for hemostasis, I for inflammatory phase, P for proliferative phase, R for remodeling phase. So first we will see hemostasis phase. What will happen whenever we have wound? Please understand. Again, hemostasis phase is divided into two things. Whenever there is vascular injury happening there, there will be endothelial injury. So whenever endothelial injury is happening and endothelium is exposed, the subendothelial extracellular matrix is exposed. So again, this will cause a platelet adhesion. So initially the charge is taken by platelets. Once the platelet is adhesion is happening, and then it will release certain granules like alpha granules. These alpha granules contain so many important cytokines and growth factors like epidermal growth factor and fibroblastic growth factor, then platelet derived growth factor, TGF beta, and vascular endothelial growth factor. Okay, so these are the important cytokines we have. All will increase the collagen deposition at the level of that particular area. Also, after the addition, there will be platelet aggregation. Meanwhile, along with this, aggregation. Along with these platelets, the another in charge at the localized wound site is your tissue factor. That is nothing but your coagulation factor 3. So this tissue factor will initiate the coagulation cascade. Ultimately, this thrombin is forming. So this thrombin will convert the fibrinogen into fibrin, which will stabilize the clot. So once the platelets are aggregated, there will be a temporary blood clot or temporary platelet plug. This will be stabilized by the fibrin by forming the factor 30. That is fibrinogen stabilizing factor. Okay. So this is the initial things that are happening in the phase of hemostasis. Right. Next, if you come to the other named phases here, we can see here inflammatory phase, proliferative phase, and remodeling phase. So once the wound is there, from that particular time, then till day 2, that is nothing but 48 hours. Initially, it will be inflammatory phase. So again, this will be divided into early inflammatory phase and a late inflammatory phase. In the early inflammatory phase, mainly platelets and polymorphonucleosides and leukocytes are taking the charge. And when it comes to late inflammatory phase, monocytes will be converted into macrophages. These macrophages will remove the devitalized tissue and also microbes, and they will regulate the fibroblastic activity in the proliferative phase. Okay, right. Next step. When it comes to next one, proliferative phase, mainly these fibroblasts are taking the charge and they will start depositing the extracellular matrix, etc. And it will last from the third day to third week or fourth week. Coming to the last one, remodeling phase or maturation phase, where these fibroblasts and myofibroblasts are acting very much, and this will be after the fourth week till the maximal period will be at around 12 weeks, where the original strength of the wound is regained by only 80%. So here one important point we need to understand is type 3 collagen, which is initially there, will be converted into type 1 collagen. So type 1 collagen. Ultimately, this is something like a type 1 is to type 3 collagen will be something like a 4 is to 1. So type 1 collagen and type 3 collagen will become in such a ratio that it becomes 4 is to 1. Okay, right. Next. Coming to the classification of wound closure and healing, we know that it is subdivided into three things. First one is primary intention, secondary intention, and tertiary intention, which is also called delayed primary intention. Okay, so primary intention is nothing but whenever we have a wound, we will close the wound with the suture material, as we can see here in this picture, and it will heal by the primary intention. Whereas secondary intention is something where we do not suture the wound. We will leave the wound open and it will gradually heal by granulation and contraction. So these are the important things that will be happening in secondary wound healing. Whereas coming to tertiary wound healing, as we can see here in the picture, initially we will leave the wound open, but after a few days or weeks, we will again suture the wound. That is called delayed primary intention, which is also called tertiary intention. So one important example for tertiary intention is your skin grafting. So initially we will treat the ulcer or wound by dressings. Then after few weeks, when the wound is completely filled with red granulation tissue, we will go for split thickness skin grafting, which is an example for tertiary intention wound healing. Okay, right. Thank you.